tubular interstitium. Enumerate and classify disease affecting tubular interstitium. So tubular and interstitial disease. Most forms of tubular injury involve the interstitium as well. Therefore, disease affecting these two components are discussed together. One is ischemic or toxic tubular injury. Second is inflammation of the tubules and interstitium or tubulointerstitial nephritis. So one is ischemic or toxic tubular injury. Second is inflammation of the tubules and interstitium. Now, what is interstitium? Interstitium is intertubular, extraglomerular, extravascular space of the kidney. It is bounded on all sides by tubular and vascular basement membrane and is filled with cell, extracellular matrix, and interstitial fluid. Now, classification. One is acute and another is chronic. Acute and chronic. Among the acute tubulointerstitial disorder, acute interstitial nephritis, infections, acute bacterial pyelonephritis, chronic pyelonephritis, other infections, therapeutic agents, antibiotic, NSAIDs, corkscrew inhibitor, chemotherapeutic agents, hypersensitivity interstitial nephritis, autoimmune disorders, tubulointerstitial nephritis with uveitis, Sjogren's syndrome, sarcoidosis, IgG4 related systemic disease, and transplantation. Acute obstructive disorder, light chain cast nephropathy or myeloma kidney. Now, chronic tubulointerstitial disorder, vesicoureteral reflux or reflux nephropathy, chronic UTI, sickle cell disease. Chronic exposure to toxins or therapeutic agents, drugs, analgesics, heavy metals, lead, cadmium. Metabolic disturbances, hypercalcemia, and or nephrocalcinosis. It is otherwise called hypercalcemic nephropathy. Hyperuricemia, urate nephropathy, oxalate nephropathy. Cystic and hereditary disorders, autosomal dominant tubulointerstitial kidney disease, previously known as medullary cystic kidney disease, and medullary sponge kidney. Miscellaneous chronic glomerulonephritis, chronic urinary tract obstruction, nephrocalcinosis, idiopathic interstitial nephritis. Now, acute tubular injury or necrosis. Acute tubular necrosis is the term used for acute renal failure. AKN is the most common and most important cause of acute renal failure, characterized by sudden cessation of renal function. Because necrosis is often not present, the term AKI is more preferred by pathologists over the older name acute tubular necrosis. So, acute tubular injury is the term, it is most preferred term. There is a separate class on this acute tubular injury. Now, tubulointerstitial nephritis. This group of renal disease involves inflammatory injuries of the tubules and interstitium that are often insidious in onset and are principally manifested by azotemia. Tubulointerstitial nephritis can be acute or chronic. Acute tubulointerstitial nephritis has a rapid clinical onset and is characterized histologically by interstitial edema, often accompanied by leukocytic infiltration of the interstitium and tubules and tubular injury. So these are the features of acute tubulointerstitial nephritis. In chronic interstitial nephritis, infiltration with predominantly mononuclear leukocytes, prominent interstitial fibrosis, and widespread tubular atrophy. These are the features of chronic interstitial nephritis. Then one thing, secondary tubulointerstitial nephritis. It is also present in a variety of vascular, cystic, that is called polycystic kidney disease, and metabolic, like diabetes, renal disorder, in which it may also contribute to progressive damage. Tubulointerstitial diseases are distinguished clinically from the glomerular disease by the following hallmarks. Number one is absence of nephritic or nephrotic syndrome. Absence of nephritic or nephrotic syndrome. Second one is presence of defects in tubular function. Now, the second one is pyelonephritis and urinary tract infection. Pyelonephritis means infection in the kidney. Pyelonephritis is one of the most common disease of the kidney and is defined as inflammation affecting the tubules, interstitium, and renal pelvis. It occurs in two forms, acute and chronic. Acute pyelonephritis and chronic pyelonephritis. Acute pyelonephritis is generally caused by bacterial infection and is associated with urinary tract infection or UTI. Serious complication of UTI that affect the bladder, kidney, and their collecting system, pyelonephritis or both. Cystitis or pyelonephritis, both can happen. Cystitis and pyelonephritis. Bacterial infections of the lower urinary tract may be asymptomatic, that is called asymptomatic bacteriuria, and remain localized to the bladder, but lower urinary tract infection can potentially spread to kidney. Now, pathogenesis. Pathogenesis of pyelonephritis or UTI. More than 85% of UTI are caused by gram-negative bacilli that are normal inhabitants of the intestinal tract. By far the most common is E. coli, followed by Proteus, Klebsiella, and Enterobacter. Streptococcus faecalis, also of enteric origin, and Staphylococcus. So the most common organism is E. coli. There are two routes by which bacteria can reach the kidney. Number one is through the bloodstream, that is called hematogenous infection. And from the lower urinary tract, that is called ascending infection. One is hematogenous infection, another one is ascending infection. The hematogenous route is less common and results from seeding of the kidneys by bacteria from distant foci in the course of septicemia or localized infections such as infective endocarditis. So ascending infection is the more common. Ascending infection is the most common cause of clinical pyelonephritis. Normal human bladder and bladder urine are sterile. Therefore, a number of steps must occur for renal infection to occur. The first step is colonization of the distal urethra and intragus in the female by coliform bacteria. This is the first step. Colonization of the distal urethra and intragus. From the urethra to bladder, organism then enters during urethral catheterization or other instrumentation. Long-term catheterization in particular carries a risk of infection. In the absence of instrumentation, urinary infection are much more common in females. So, this is the route of ascending infection and this is the route of hematogenous infection. Ascending infection, bacteria enters, then deranged vesicoureteral junction, vesicoureteral reflux, and intrarenal reflux. It goes to the kidney. Now, acute pyelonephritis. Morphology. The hallmark of acute pyelonephritis are patchy interstitial suppurative inflammation, intratubular aggregate of neutrophils, neutrophilic tubulitis, and tubular injury. In the early stage, the neutrophilic infiltration is limited to the tubules. Infection can extend to the interstitium and produce abscess that destroy the involved tubules. Characteristically, glomeruli are relatively resistant to infection. Extensive disease, however, eventually also destroy the glomeruli and fungal pyelonephritis by candida, often resulting in granulomatous interstitial inflammation. This is the gross picture of acute pyelonephritis. Microscopic picture of acute pyelonephritis. There is a marked neutrophilic exudate. These are all neutrophils within the tubules and interstitial inflammation. Three complications may be superimposed on acute pyelonephritis. Number one is papillary nephrosis. Number two is pyelonephrosis. Number three is perinephric abscess. These are the three complications of acute pyelonephritis. This is the picture of papillary necrosis. These area are necrosed area. This area. Acute pyelonephritis usually presents with a sudden onset of pain at the costovertebral angle and systemic evidence of infection such as fever and malaise. There are often indications of bladder and urethral irritation such as dysuria, frequency, and urgency. The urine contains many leukocytes, that is called pyuria, derived from the inflammatory infiltrate, but pyuria does not differentiate upper from lower urinary tract infection. So pyuria is a feature which is common in both upper urinary tract infection and lower urinary tract infection. The finding of leukocyte cast, typically reaching neutrophils, that is called pus cast, indicates renal involvement because casts are formed only in the tubule. The diagnosis of infection is established by quantitative urine culture. Now, chronic pyelonephritis and reflux nephropathy. Chronic pyelonephritis is a disorder in which chronic tubular interstitial inflammation and scarring involve the calyces and pelvis. So these are the important features. In chronic pyelonephritis, there is the presence of inflammation and scarring. Although several diseases produce chronic tubular interstitial alterations, only chronic pyelonephritis and analgesic nephropathy affect the calyces, making pelvic axial damage an important diagnostic clue. So pelvic axial damage is a feature of chronic pyelonephritis and analgesic nephropathy. Morphology. The characteristic changes of chronic pyelonephritis are seen on gross examination. The kidneys usually are irregularly scarred. If bilateral, the involvement is asymmetric. In contrast, both kidney and chronic glomerulonephritis are diffusely and symmetrically scarred. So, in chronic pyelonephritis, it will be scarred and bilateral involvement is asymmetric. In chronic glomerulonephritis, it is diffusely and symmetrically scarred. Here it is symmetrical, here it is asymmetrical. The hallmarks of chronic pyelonephritis are coarse, distinct, and corticomedullary scars overlying dilated, blunted, or deformed calyces, and flattening of the papilla. The scars vary from 1 to several. The most are in the upper and lower pole, consistent with frequency of reflux in these sites. The microscopic changes involve predominantly tubules and interstitium. The tubules show atrophy in some areas and hypertrophy or dilatation in others. Dilated tubules with flattened epithelium may be filled with cast resembling thyroid colloid, or it is called thyroidization. Resembling thyroid colloid, it is called thyroidization. It is the gross features of chronic pyelonephritis. It is the microscopic picture, shows corticomedullary renal scar with an underlying diabetic deformed canis, and these are the thyroidization. Chronic pyelonephritis, microscopic picture, hyalogized glomerulus, periglomerular fibrosis. It is thyroidization. These are the hyalogized vessels. These are the thyroidization. Now, clinical features. Chronic obstructive pyelonephritis may have a silent onset or present with manifestations of acute recurrent pyelonephritis, such as back pain, fever, pyorrhea, and bacteriuria. These patients receive medical attention relatively late in their disease course because of the gradual onset of renal insufficiency and hypertension. So these are the clinical features of chronic obstructive pyelonephritis. So clinical features are back pain, fever, pyorrhea, and bacteriuria. Radiographic studies show asymmetrically contracted kidneys with characteristic core scars and blunting and deformity of the calcium system. Significant bacteriuria may be present, but it is often absent in the late stages. Now, tubulointerstitial nephritis induced by drugs and toxins. Drugs and toxins induced tubulointerstitial nephritis is the second most common cause of acute kidney injury after pyelonephritis. So this is the second most common cause of acute kidney injury, tubulointerstitial nephritis, induced by drugs and toxins. Toxins and drugs can injure kidney in at least 3 ways. Number 1 is trigger an interstitial immunologic reaction, exemplified by the acute hypersensitivity nephritis induced by drugs such as methicillin. Number 2 is AKI, cause AKI. Number 3 is cause subclinical but cumulative injury to tubules that takes years to result in chronic kidney disease. So the 3 ways, number 1 is trigger an interstitial immunologic reaction. Number 2 is cause acute tubular injury. Number 3 is cause subclinical but cumulative injury to tubules. The last type of damage is especially worrisome, means this one, because it may be unrecognized until the renal damage is irreversible. That's why. Then acute drug-induced interstitial nephritis. First reported after the use of sulfonamide. Acute tubulointerstitial nephritis most frequently occurs with synthetic penicillin, other synthetic antibiotics like rifampin, diuretics, NSAIDs, non-steroidal anti-inflammatory drugs, miscellaneous other drugs, allopurinol, cimetidine, checkpoint inhibitors. The chronic tubulointerstitial nephritis caused by ferracetin containing analgesic, termed analgesic nephropathy, is of historical importance as its incidence has substantially diminished due to withdrawal of restriction of ferracetin in most countries. Drug-induced acute interstitial nephritis begins 2 to 4 years after drug exposure and is characterized by fever, eosinophilia, rash in about 25% of patients, and renal abnormalities. The latter takes the form of hematuria, mild proteinuria, and leukocyturia, often including eosinophils. A rising serum creatinine or acute kidney injury with oliguria developed in about 50% of cases. So, the clinical features is fever, eosinophilia, rash, and renal abnormalities. Now the morphology. The interstitium shows variable but frequently pronounced edema and infiltration by mononuclear cells, principally lymphocytes and macrophages. Eosinophils and neutrophils may be present, often in clusters and large numbers, and smaller numbers of plasma cells and mast cells are also sometimes present. So, findings are mononuclear cell, principally lymphocyte, and macrophages, then eosinophil, neutrophil, plasma cell, and mast cells. Drug-induced interstitial nephritis microscopical pictures with prominent eosinophilic, these are eosinophil, and mononuclear cell infiltrate. These are mononuclear cell means lymphocytes. These are lymphocytes, these are eosinophil. Now, the other tubulointerstitial disease, number one is urate nephropathy. Three types of nephropathy can occur in persons with hyperuricemic disorder: acute uric acid nephropathy, chronic urate nephropathy or gouty nephropathy, nephrocalcinosis, hypercalcemia and Nephrocalcinosis. Disorders associated with hypercalcemia such as hyperparathyroidism, multiple myeloma, vitamin D intoxication, metastatic cancer, excess calcium intake, that is called milk alkali syndrome, may induce the formation of calcium stools and deposition of calcium in the kidney, that is called Nephrocalcinosis. Extensive degree of calcinosis under certain conditions may lead to chronic tubular interstitial disease and renal insufficiency. So, disorder associated with hypercalcemia, hyperparathyroidism, multiple myeloma, vitamin D intoxication, metastatic cancer, and excess calcium intake. The earliest functional defect is an inability to concentrate the urine. Other tubular defects such as tubular acidosis and salt-losing nephritis may also occur. With further damage, a slowly progressive chronic kidney disease develops. It is usually due to nephrocalcinosis. But many of these patients also have calcium stools and secondary pyelonephritis. Then, autosomal dominant tubulointerstitial kidney disease. It was previously known as medullary cystic kidney disease. Even the variable presence of cysts, which often are not located in the medulla, and the distinctive genetics, it is now recognized as ADTKD due to following genetic mutations: MUC1, UMOD, NTOX uromodulin, REN, HNF1 beta. These four mutations. Then light chain cast nephropathy or myeloma kidney. Non-renal malignant tumors, particularly those with hematopoietic origin, affect the kidneys in several ways. The most common involvements are tubular interstitial, caused by complications of the tumor, hypercalcemia, ureteral obstruction or therapy, irrigation, hyperuricemia, chemotherapy. Several factors contribute to renal damage, like Bain-Jones proteinuria and Cast Nephropathy. The main cause of renal dysfunction is related to Bain-Jones proteinuria and correlates with degree of proteinuria. Then amyloidosis of AL type light chain deposition disease, hypercalcemia and hyperuricemia. Then bile cast nephropathy. Impairment of renal function often occurs in patients with severe acute or advanced chronic liver disease. In this setting, serum bilirubin level can markedly elevated particularly in jaundice patient with bile cast formation.